Hello, ladies and gentlemen. Welcome to Triple N Media. I am Dr. Nik Nikam. On our YouTube channel, we have more than 300 cardiology lectures, starting all the way from basic science up to 2022 ACCH guidelines. So you're welcome to watch those, and then please do subscribe to our YouTube channel. At the end of this presentation, I'm going to tell you how you can get a copy of this cardiology rotation manual with more than 250 pages of pertinent information from history taking to clinical evaluation and all the guidelines that have been published in cardiology field. The feature presentation is a cardiology board EKG interpretations, intraventricular conduction changes. For those who are taking cardiology boards, you will be familiar with this answer key sheet used for interpreting the electrocardiograms. So we're going to use the same format to understand what are the EKG findings we need to be familiar with. You can follow these steps, then you will be as good as a cardiologist in interpreting the electrocardiograms, whether you're in the emergency room or you're a primary care doctor or you're seeing a patient in the hospital. I have created a video that covers the entire answer key sheet, and please do watch that one. And I also have created separate videos for each one of these segments, and I have covered atrioventricular conduction delays, hypertrophy, clinical disorders. Today we're going to focus upon the interventricular conduction disturbances. Following that, I will have a separate video for myocardial infarction and a separate video for STT changes, which is a big topic where there are going to be quite a number of questions, and also pacemakers. So let us focus in this presentation on intraventricular conduction. Before we go into the intraventricular conduction delays, we need to look at the electrical system of the heart, which is the sinus node here. Then we have the interatrial connections that connects to the AV node. Then we have a Bachmann bundle that supplies the left atrium. And we are going to be mainly concerned about the conduction disturbances related to the right and the left bundle branches and their subdivisions, and the AV nodal connection problems have been discussed earlier in the AV conduction disturbances. We will be talking about the right bundle branch block. We're going to be talking about the left bundle branch block complete, or left anterior hemiblock, or left posterior hemiblock, along with intraventricular conduction delay and some other conditions that cause conduction disturbances in the ventricular rhythm or the ventricular part of the QRS complex, depending upon the refractory period and also the rate. So let us continue with the feature presentation. Let's focus upon the right bundle branch block. Some of the salient features of right bundle branch block include there's an R, S, or like a dominant R in V1. Then we have right may or may not have right axis deviation, but we are going to have a slurred terminal S wave in the anterolateral leads. I'm going to show you examples of all these. The QRS complex will be greater than 120 milliseconds or 3 boxes. We're going to see discordant STT changes in the right chest leads. There will be no change in the electrical axis of the heart. And if the QRS duration is between 110 and 120 milliseconds, it is considered as incomplete right bundle branch block. So let's remember these things. This is an interesting EKG. Here we have what appears to be, if you look in the rhythm strip, we got a P wave here, here's a P wave, here's a P wave, here's a P wave, here's a P wave, here's a P wave. You just have to imagine. So we have what appears to be a rate that is faster than 100. So we have like a sinus tachycardia. Then we have the ventricles, which are beating at a totally separate rate, and the QRS complexes are similar. It has a right bundle branch block pattern along with the terminal S waves in the lead 1 AVL, and also from V4 to V6 lateral chest leads. So this is an example of a complete heart block with the right bundle branch block pattern. This is probably a junctional escape rhythm with right bundle branch block, unless it's not slow enough to be idioventricular. So this is right bundle branch block pattern junctional rhythm with AV dissociation and complete heart block because the atria are beating independently and there's no evidence of any fusion beat I can see. Otherwise, you would have seen a deformity in the QRS complex if there were some conducted beats. Good. Let's move on to the next one here. Here's a more simplified EKG compared to the previous one. Here we have the sinus beat, and we have terminal S wave. Whenever you see terminal S wave here, just in lead one, you can be almost certain you're dealing with a complete right bundle branch block or incomplete right bundle branch block. As we can see here, we have an RSR prime with discordant STT changes. And an interesting finding in this electrocardiogram is in addition to the complete right bundle branch block, we also have left axis deviation, left anterior hemiblock. Putting together, it represents the bifascicular block. And the third interesting point I see here is the PR is approximately 120 milliseconds, so it's not short, but it appears short in this electrocardiogram. Nonetheless, and then we have the left axis deviation, which I talked about. So to summarize, we have a sinus rhythm, left axis deviation, left anterior hemiblock, along with some non-specific T-wave changes here in the high anterior leads with right bundle branch block and discordant STT abnormalities related to the right bundle branch block. Now let's talk about the anterior fascicular block. In the previous diagram, I showed you the electrical system of the heart. The anterior fascicle is the smaller one compared to the posterior fascicle, which goes all the way around the apex of the heart and supplies the lateral wall. The anterior fascicular block results in a QRS duration of less than 120 milliseconds. It produces a more negative deflection in lead 2, and the time to peak R wave in AVL will be greater than 45 milliseconds. That's the intrinsicoid deflection, how long it takes for it to reach the peak in AVL. Remember that one. Then lead 2, 3, and AVF will show an RS pattern or predominantly S pattern in lead 3 and AVF. And these leads in 1, AVL, V5, and V6, this should be show QR complex pattern. There's a tiny Q wave, and then we see a long, tall R wave. And here's an example of a left axis deviation, a sinus rhythm to start with. Then we have sort of peaked P waves. You wonder if there is evidence of some right atrial enlargement, which may be substantiated by the fact that we have some dominant R waves in V1 and V2. So this could be some evidence of right ventricular hypertrophy. Anyway, so we have left axis deviation, and since the negative deflection is more than the positive deflection, it is more than minus 45 degrees. So we are talking about left anterior fascicular block or left anterior hemiblock as it is called. So we have sinus rhythm, left axis deviation, left anterior hemiblock, possible right atrial enlargement, and maybe some right ventricular hypertrophy, and the rest of the electrocardiogram looks okay. The left posterior fascicular block, the QRS axis is greater than 120 degrees. The QRS width is less than 120 milliseconds. The RS pattern in 1 and AVL. So we have a small R and a deep S wave. Whereas in lead 2, 3, AVF, we have a QR complex, a tiny Q and a positive R wave. In 2, 3, AVF, this is opposite of what we saw in the left anterior fascicular block. And we need to exclude other conditions like right ventricular hypertrophy, pulmonary embolus, COPD, or lateral myocardial infarction. And here is an example of a computer-generated EKG showing right axis deviation. Then we see an RS complex or a QR complex, as we can see here, as opposed to the other one where we had a RS deep S wave in 2, 3, and AVF. Along with that, we can also have this R wave and a negative deep S wave in 1 and AVL. So this is a picture of a left posterior fascicular block. It is uncommon. The left anterior fascicular block is much more common. Overall, the incidence of the fascicular blocks, we are talking about just left anterior fascicular block or left posterior blocks are like 2 to 3% in the general population. Anyway, so here we're going to talk about Brugada syndrome. And Brugada syndrome is characterized by J wave amplitude. The J wave is lifted from the baseline, and there is a rounded top. Then we have a downsloping ST segment and a broad inverted T wave. And this is exactly what we are seeing here. The J point is elevated, which blends into the downsloping ST segment, and we have a T wave inversion. This is type 1 Brugada syndrome. Type 2, we see a saddle back type of ST segment. This is a downsloping ST segment. This is the saddle back type 2. ST segment elevation is there, but it is less obvious compared to the type 2. And also the T waves more or less appear to be lifted 1 millimeter from the baseline. Sorry, the saddle back type of ST segment and a T wave inversion, and this is more obvious, whereas this one is sort of a smooth downsloping ST segment as opposed to the elevated J point. The J point elevation is less pronounced in type 3. The main thing is this gradual slope. The ST segments are elevated slope, whereas the ST segments here are elevated from the baseline, and that is the key factor. And here is an example of another right bundle branch block with left axis deviation, left anterior hemi block, and some T wave changes. Looks like the previous EKG we saw. Anyway, here is an example of what appears to be a complete left bundle branch block involving both the anterior and the posterior fascicles. We can see we have a wide QRS complex, delayed intrinsicoid deflection, as you can see from here to here, along with left atrial enlargement or abnormality and some discordant STT changes, especially in V5. Maybe the leads are placed a little more laterally. You may be able to see them in V5 and V6 also. And it's also characterized by deep QS, wide QS complexes. It is not like the QS complex you see in an acute myocardial infarction. Here, this QS complex is pretty wide. So these are some of the features of the left bundle branch block, and here is another example of a left bundle branch block. As we can see, this wide QRS complex in 1 and AVL. We have deep S waves in V1, V2, V3, and again this wide QRS complex measuring more than 120 milliseconds. Along with that, we have left axis deviation, left anterior hemi block. The left atrium doesn't quite meet the criteria for left atrial enlargement, but there are multiple findings here to suggest left bundle branch block. And here are some of the important features you need to be familiar as far as the left bundle branch block is concerned. The wide QRS complex in lead 1 and AVL, as we saw in the previous two tracings. The lateral chest leads with notched at the top. This is the notch they are talking about, this notch in the chest leads. We don't see it here. Here we see it here, the notching of the R wave. The QRS duration can be up to 140 milliseconds. When you get more than 140 milliseconds, we are talking about more serious conduction disturbances, not necessarily related to the bundle branches, but also related to the propagation of the impulse within the myocardium itself. And there are discordant STT changes. I talked about tiny R waves in anterior leads followed by deep S waves, and of course the R wave in the lateral leads exceeding more than 60 milliseconds. That is the intrinsicoid deflection, how long it takes for it to reach from the beginning of the QRS complex to the peak of the R wave. You need a magnified image to look at that. A notch in the R wave in the lateral chest leads resembling M pattern, and this is what they were talking about, M pattern. Just as we would see like a RSR prime here, if this is the left side is the prominent one, the second one is the right side of the heart deflection of the electrical impulse. So those are some of the findings as far as left bundle branch block is concerned. So please remember this, it is important to find all these criteria. Can we diagnose myocardial infarction in a patient with a left bundle branch block? Obviously, if someone comes with a severe chest pain and if they have a left bundle branch block, and if this is a new onset left bundle branch block, then chances are that may be an indication of an acute ischemic event. And that's what it is considered as. Whereas if we see an ST elevation of 1 millimeter in the same direction as the QRS complex, it is 5 points. As I told you before, we see these discordant STT changes. Whereas if this person were to come to the emergency room with chest pain, and this patient had his EKG before, and now we see an ST segment which is elevated 1 millimeter and an upright T wave, that is significantly important in terms of an acute myocardial ischemia or injury. The second point is ST depression of 1 millimeter in V1, V2, or V3. And if you look at here in the electrocardiogram, generally the ST segments are anywhere from like 3 to 10 millimeters above the baseline in patients with left bundle branch block. Whereas if you see an ST depression instead of an ST elevation, then that is definitely indicative of an acute ischemia or an ongoing ischemia. Similarly, ST elevation of greater than 5 millimeters in the opposite direction, you get 2 points. You need 3 points to diagnose the presence of acute myocardial infarction in the presence of left bundle branch block. All right, so let's look at here. We have what appears to be an incomplete left bundle branch block, or intrinsicoid deflection, or intraventricular conduction delay as it is called. It looks like left bundle branch block, but the QRS duration is less than 120 milliseconds. There's no left axis deviation. There's nothing else to suggest, but since the QRS duration is greater than 110 milliseconds, we have to call this as intraventricular conduction delay. All right. And another phenomenon that we see is like a bundle branch block pattern in a supraventricular beat that follows a long RR cycle, which is generally seen in patients with atrial fibrillation with variable ventricular response, where we have varying RR intervals. And anytime you see a long RR interval followed by a beat that comes with a short interval, because of the refractoriness of the conduction system, we see a bundle branch block pattern which looks like a wide QRS beat, but this is actually a supraventricular beat with aberration, which is known as the Ashman phenomenon. So you need to be familiar with the Ashman phenomenon. Okay, here's an example of a rhythm which has it's an interesting rhythm because the underlying rhythm is atrial flutter, because if you see the notches here on the dot on every heavy fifth line, so the atrial rate is like 300. And then we have a narrow QRS complex, then we have a wide QRS complex, narrow QRS complex, wide QRS complex. So is this ventricular tachycardia in the presence of atrial flutter? That's why they're asking, does this patient need lidocaine? Now that's the last thing you want to use in this patient, because if you got an atrial flutter and you try to use lidocaine, then this conduction can go into one-to-one conduction. So that's not what you really need. You need drugs that block the AV conduction to reduce the rate. And when you reduce the rate of the ventricular conduction, ventricular rate, then we're going to see the narrow QRS complexes returning. So this is a atrial flutter with here we can see a nice 3-beat rhythm strip here, followed by relatively short cycle compared to the previous longer cycle sets of an aberration which looks like ventricular tachycardia, but this is atrial flutter with variable ventricular response. So, ladies and gentlemen, this is a quick overview of the conduction disturbances with reference to the cardiology board exam EKG interpretation. If you would like to get a copy of this 250 pages of cardiology book, please drop us an email and tell us where you are from and what is your specialty and how this book would be useful to you in your practice. And you can send me an email to drniknikam@gmail, and I'll be happy to get you a copy of this cardiology rotation manual. Thank you so much for watching this presentation, and please do subscribe to our YouTube channel, and I will see you in the next presentation.